So here we are, we're at the end of this awesome conference. No pressure, but this was the culmination right here. So no pressure when you get up here, but I hope you solve the problems in your small groups because that's what it was all about. So we're going to hear from all three groups. We're going to start, Dennis is here, so Dr. Dennis DeLugos is going to give us the summary of Breakout number 1, which was how can we create better trials to accurately measure seizures in LGS.
All right, thank you, Scott, and thanks to everybody who was in Breakout Room 1. I think I learned more in there than I have in like the last 5 or 10 epilepsy meetings. So it was, I think, very helpful. So we spent a little bit of time on better trial design, big picture. The time to event design at least merits awareness on the part of sponsors. It has some advantages, it has some disadvantages. We did talk about prospects for preventing LGS. Challenge with that is you have to know when it starts or when it might start, and that's hard. It would be a big ask to prescribe an intervention to prevent to everyone who is at risk for LGS. So that is a hugely important topic, but really tough sledding at this point. Then we mainly talked about seizures as our outcome and better ways to identify seizures. Seizure-free days, courtesy of Dr. Wheelis's comment yesterday, and there's a recent publication by Stefano Vaughn and others on seizure-free days as a possible outcome. It has clinical appeal. It is, but the devil's in the details. You still have to count because you have to know whether it's 0 or more than 1. You're missing a lot of data in your primary outcome, so you'd be choosing to miss a lot of data unless you have secondary outcome as seizure reduction, in which case you're back to counting. So definitely worth reading the recent paper, Yvonne et al. On seizure-free days. It was a post hoc analysis, but also devil's in the details. So then we tackled the necessary evil, as Dr. Perry said, counting seizures in our somewhat traditional ways. So the hugely important message, and I think it merits maybe a full session, panels, whole group involvement, is not just the burden of the seizure diary on families, caregivers, parents, observers, but ways to lessen that burden. I mean, we all know that seizure diaries are inaccurate, but the burdensome nature at home, I think, needs attention, and there were really powerful messages and good suggestions. Train the parents. You know, we talk about, and I said it, you don't have, we don't expect 100% accuracy, but consistency is important. What does that mean? Tell me, spend time at the visit. Invest dollars as you're planning your study about what does it mean to consistently count seizures. At home, at school, how many hours a day? So flesh that out. Make sure the parents and anyone else who's counting seizures spend more time on seizure training. Behind the scenes, we talk among ourselves about drop seizures are the following 5 seizure types. And then there's non-drop seizures, and more time needs to be spent delivering that in a digestible way to families. So more time training on seizures, more time, more attention to consistency. The actual diary. There are advantages to electronic diaries, but there were some great suggestions in there about how to make them more practical. So imagine not a wearable for the patient with seizures, but a wearable for the parent, the caregiver, who's identifying seizures, and imagine it had 2 buttons. There was a primary outcome seizure that just happened. There was a secondary outcome seizure that just happened. Click, a 2-button wearable. And then you'd have to flesh out at some point later, all right, that primary outcome seizure, was that a tonic-clonic? Was it a tonic? Simplify the identification in real time of observers, caregivers who have to count the seizures. Alexa, tonic-clonic seizure. Alexa, focal motor seizure. It's like, I'm like, this is, I mean, I talk about this all the time, and we never hear things that are this helpful. So those were some of the summaries of ways to make our diary better. So then we delved into more objective measures. Two things. The ceiling-mounted camera to detect nocturnal tonic seizures. Great, visual identification, AI supplemented. We'll get accurate counts of clinical tonic seizures, but beware, co-sleeping is common, and the camera is not necessarily going to be welcomed by all parents. Hugely important point, because there's a lot of appeal to the little camera that's going to give you an accurate count of your nocturnal tonic seizures. And then EEG. Okay, 12 or 24 scalp electrodes, not going to happen for prolonged periods of time. What can we do with prolonged EEG? Roof of the mouth, subcutaneous EEG sensor that gives you good frontal lobe bifrontal coverage. Let's assume you'll get accurate detection of tonic seizures with a subcutaneous EEG sensor. Invasive surgery, anesthesia, healing did not get great reviews. Two ear electrodes stitched in. They're gonna tug. Also sounds great to the EEGers, but got the baseball cap. The baseball cap that could detect seizures accurately. That, I think, got the most love in the room. You got to figure out, how to keep it on and how long do you wear it? Do you wear the cap 2 hours a day, 4 hours a day? So those were some helpful insights. And then what we really need, and I agree, I just don't know how to, it's a hard lift to get there. We need to stop focusing on seizures and focus on biomarkers of seizure susceptibility, of what is the basis of the epileptogenic network in that person. So biomarkers of seizure susceptibility, yes. And, but I think that would take a very thoughtful, detailed, step-by-step map of how we get there from our current knowledge or lack of knowledge to a clinically relevant regulatory and acceptable outcome measure from the regulatory agency's approach. So that's my summary. So feel free. It was such a great discussion. I wish you all could have been there. Anyone who was there that anything I left out or didn't emphasize enough, please. Let's see, is the gentleman in the room who, yes. Is there a microphone?
There should be mics. Yeah, there we go.
And how much time do you have?
Give us the Cliff's notes, so like 3 minutes. Is this you, Aaron? Yeah, okay.
I guess, we don't know, but I think there are some examples outside the epilepsy domain that we could be inspired by. I guess, my interest is obviously in sort of like implantable neurostimulation space, and those biomarkers are not going to be sort of widely applicable. But I think if we start there to identify, like in like movement disorder literature, there's now sort of like biomarkers of beta band power and sort of suppressing that as a sort of way of measuring disease severity. And that was sort of like identified from, like the DBS literature. And if we could do the same thing in epilepsy and then find a way of measuring those things non-invasively, yeah, I guess that's what I mean by that.
Great, thank you. That
All
was-
right.
That was helpful. I think from the parent standpoint, because the first thing that came to my mind was parents saying that if they're overstimulated, right? Like that was the first thing that came to my mind. So I appreciate the comment. If they're overstimulated, or if it's between, we call them the witching hour, right? If it's during witching hour seizures, right? Like that's so there's a parent's way of thinking about this. So I appreciate those comments. Thank you.
All right. Anybody else from the room? All right. Thank you. Thank you very much.
All right, that was great. I love the Alexa idea, but I imagine, saying Alexa seizure and then there's a little Caesars on West 7th Street. Would you like me to give you the number? Yeah, that's what I imagine happening. Okay. All right, we're going to go to group number 2. This is Jim Wheelis. How can we create better studies to accurately measure LGS-associated comorbidities? This was a huge group, so you guys must have a ton of stuff.
All right, thanks, Scott. So yes, so measuring and counting were critical to doing this, and I have to remind you before we start is Einstein's famous quote about this, which I think applies exactly to what we talked about, and you have to listen carefully. Not everything that can be counted counts, and not everything that counts can be counted. And that's the challenge that we have with this. So having that challenge, we said, okay, how do we look at kind of the associated neurologic disabilities, the AND phenomena? And so we kind of started off in a couple different ways. So one was kind of which ones did we feel like were categories that were high on our list of items to even try and address that are non-seizure. I would say probably behavior was way up there with a lot of subdivisions, all the way from disruptive behaviors, impact on the patient and family, kind of anxiety, mood, compulsive behaviors. As we get transitioned to adolescence, sexuality, some of those behaviors that may come out. Other kind of categories, communication was a huge one. As well. Sleep was a big one. And then we had kind of development, GI, other ones. So several categories of kind of behaviors and how do we start to kind of hierarchy those and say, and then the other one, which Peter must be back taking care of patients, okay, is even splitting everything we do out by different age groups. So is it preschool age kids, and then do we go from there to like school, pre-adolescents, adolescents, then maybe adults, because realizing these are moving targets depending on the audience that we're dealing with and the age of the patient, and really realizing that there's probably absolutely zero in the adult world because there's more of these folks that are getting there and they didn't used to be there, and we just have zero data. And a lot of this in adult, it's been very pediatric focused. For some of these, the idea that not just capturing the behavior, but trying to figure out like, duration, severity, that also is important as well. Can we do this in a pilot manner? And we discussed, using kind of I won't say borrowing would be a better word than stealing. That was Tracy's word. But borrowing maybe surveys that are already there that sample these from other developmental epileptic encephalopathy groups, piloting them as electronically based in maybe a set of clinics that are seeing these folks just to say, okay, is this helpful information? Is it getting at the core symptoms we want to get at, and then refining that to say, okay, if it actually is working, that's great. Then we can use that to say we actually are, have something, we know priorities, now we just got to develop measurements. So that was our second category, I guess, was, okay, how do we kind of start to think about how do we measure some of these? Do we do by kind of like seizure-free days? Do we do by kind of days of the month that, you name it, the behavior, the seizure, the sleep problem, the mood disorder, whatever it is you're concerned about, that, this occurred and it impacted the child, the adolescent, the adult, and or the family for how long? Did it impact them? It ruined the whole day for everybody? It ruined the week for everybody? Whatever. So how long, does that help us if we kind of can figure that out for the behaviors too, is kind of what's the impact, if you will, of some of these other disorders beyond the seizures, and we can also kind of fill in that blank for, who was impaired by it. Was it just the patient? Was it the patient and one parent, the patient, the parent, the whole family? Was it the whole school classroom? Who was impaired? So we can kind of figure out, does that get us a better feel for getting a better handle on it? And again, all those have got to be validated for different age groups. That's going to be a kind of common theme here as well. Communication is a tough one. There's a lot of work to be done there. We realize just, receptive, expressive, but just kind of just the impact that communication has with all of these areas, kind of impacting kind of positive and negative ways that we've got to kind of do that. And then our final, I guess, category was kind of saying, gosh, we have to start somewhere. We have all these associated neurologic disorders. We have clinicians out there being asked to tackle those when they see these kids and for their seizures, and kind of doing their best guess at doing it. But can we start with a white paper or equivalent thereof with experts in the different areas saying that, gosh, in someone with LGS, we probably don't have any randomized controlled trials for, what happens when you have a sleep disorder, or what happens when you have, aggressive behavior, or you name it, fill in the blank. But do we at least start to say these are our expert opinions, and then that is the stepping stone in the areas that we have big holes for then Tracy and the group to say, we've got to fund research in these areas for the next couple of years because there's huge holes, and these, ranked high on our families of big needs, and we look at kind of current treatments, we have holes, so we need to match these up and move quickly into funding research in those areas. And that seems to be a logical progression, at least to me, as well. So that's kind of what we did. And questions, comments? We had a great group. Did I leave out any major areas? Anybody from the group want to comment? Beyond Tracy? Just kidding.
So Renee Shellhouse and Gita Gupta pointed out that we did not talk about pain. And I think that's a really big area as well. So thank you, ladies.
We mentioned the thermal scanner with Pan, I guess, but we didn't really, yeah. Okay. Thought we figured it out.
If anyone in the audience, too, has any thoughts, like if you weren't in group 2, but you feel like, you had something you wanted to add, please don't hesitate to raise your hand. But other than that, any? No?
All right, back to you, Scott. Tag, you're in.
Okay, last one is breakout number 3. How can we address the unique needs of adults with LGS? And Jen Griffin is going to lead that one.
All right, I look at that. Sorry, Lori, I should have carried that. Look at the giant Post-it over there. It's got 3 things on it. We're like the overachievers in group 3. So the old Latrobe department. Hang on, let's start on the first page, maybe where we started. So you all heard Dr. Crino, and he said that in the neurology, adult neurology world, there is not a lot of training. There's no training for neurodevelopmental disorders. So if we had a bucket of money, and so we were told to just dream, right? So we would, hopefully find a way to fund some training. I can't see that, but maybe, here we go. So we sort of identified a lot of problems in the beginning, and we talked about things like, there aren't a lot of organizations and supports that have behavioral and medical needs all in one. It's kind of an either or. And so maybe a solution to that would be, multidisciplinary teams. And then also that whole transition period from peds to adult is really challenging, obviously, for both the provider and for the caregivers. So maybe some sort of education that, that we could really come up with something that for both sides so that everybody comes to this new relationship, with their best selves. Because really, initially, we were thinking about, those caregivers that are really super savvy now, and they may have, and they're initially going to be the expert in that room on their child because the healthcare provider maybe doesn't have a lot of information on that individual. And so how are we going to be, maybe on the second page, we had like a checklist that we can come up with for the providers, because a lot of times there are also the family members that are not super savvy, like some, and we're getting a lot of these in the LGS community, and we had one in the room who they're new to the actual diagnosis in adulthood. So are those caregivers or are the providers asking the questions, making sure that they've had an EEG or, blood work, certain type, whatever it is, some labs, whatever they need to do, genetic testing, a lot of the things that don't necessarily come up in those initial visits. And also we were talking about, legislation and how there needs to be a lot of resources and inpatient facilities that, governments have taken away a lot of those resources, and we need to get them back for our loved ones. And so that also brings us to the fact that some of the people that are taking these individuals to their appointments are not their family members. Maybe there isn't a family member around. And how are we, so they may not be great advocates for that person's health care, which obviously that puts a lot more onto the healthcare provider, but somebody has to do it, right? So maybe a lot of these checklists and one-pagers or something that would help to keep everybody informed and asking the right questions, and for whoever the caregiver is to be reporting back the right kind of information on that loved one. And then we talked about partnerships. I don't think if you put all the DEEs together and had us advocating for maybe doing the legislation or advocating for just keep individuals with all DEEs, it still wouldn't be enough. We need to go, I think, outside of the DEE community, like to places like the ARC and organizations that focus a lot on how to have quality of life for individuals, adults with these specialized healthcare needs. And also, a little aside, we also talked about how sometimes even in the individuals with intellectual and developmental disabilities community, our folks are sometimes ignored because they're maybe, I always say, Tracy and I've had this conversation, they're a little too special for the special community. Earlier we heard about how people are afraid of dealing with babies, and they might be afraid of babies. Well, people are terrified of people with seizures. So even if they have, if they're in a day program or something like that, they may not be able to be admitted into that because they require so much individualized attention. And of course, there isn't funding for that. And then we talked about some, all the different things we could develop, like legal kits that have a lot of information, so that when there's succession planning, if you're handing over the care of your loved one to a new person, be it a sibling or be it a professional in a group home environment or something, there has to be some sort of a resource for them, and a lot of it has to do with things like the legal stuff, like guardianship and all of that. And then maybe if we. Do you want to take over from here?
So we identified all these different areas and gaps, and we talked about all the different ways that we could brainstorm. And so we're going to take this big, giant pile of money that we have, and we're going to run a couple of pilots. So one of the issues, we know that there are, caregivers are going to have to work hand in hand with healthcare professionals, right? It can't just be the caregivers, it can't just be the healthcare professionals, but there just are not resources that are available to make this happen in a succinct way or efficient way, or the way that we want to be able to take care of our loved ones. So we will start a pilot study by hiring somebody who would be like an advocate, like a case manager for a state. We eventually would want to see one in every state, but we would pilot it in one state as a resource for a caregiver to be able to help them navigate transition and all the different aspects that come with long-term care planning with, for your adult with rare epilepsy. And we would have that person be an expertise in that particular state, all the different rules and things like that, because it's so, so difficult. One of the big issues, like even if you have dedicated people, and it's understanding the constant change in Medicaid and all the different programs and rules, and it's just overwhelming. You're so overwhelmed with everything else that you have to do, and now you have to navigate all these things. And so understanding by state what the resources are, where do you go, how do you do these things. And so we thought if we had a pilot to have a case manager to help navigate that, how would that change the outcomes? How would that decrease the cost, the burden of care, and all those different things? And would this be a good investment to have people like this who would be able to help caregivers navigate this? So that was one thing. And then with the education with the healthcare professionals who maybe, were not trained, they don't know anything about DEEs, and having that checklist or having, those different resources that Jen talked about. While we want to point people to centers of excellence because we know that's where they're going to probably get the greatest care, that those centers get overwhelmed. Everybody wants to go to a center of excellence, and a lot of people can't get there. And so we have to think about educating more broadly with different physicians and even in family practices and things like that, because everybody's not going to have an epileptologist. Everybody's not going to have a neurologist. It's just not going to happen. And so, and it's not just the clinicians either. It's the nurses, it's the staff, it's everybody that's in that practice. Because when you go, for example, on transition from peds to adult, it is jarring, it's shocking, and it's such a different environment, and it's very, these people, they're just not trained, they just don't know how to do it. So we would look at getting maybe a small practice and doing a pilot in bringing all this education and helping them to learn how to care for, patients with DEEs, and then see how that goes. And if we can be successful in bringing like a center of excellence to a practice, can we then duplicate that and disseminate that with other practices? But we need to go more broad in order to get that education piece out there. And then what was the other thing?
When we were talking about a checklist, we also suggested a publication as well.
Yeah. And I think the thing. Oh yeah. I wanted to say that I think a thing on the checklist. So one of the things that we talked about too is, this is great when you go through transition. There we'll have checklists, we'll have guides, we'll have resources for that. But what if you find out when you're 30 that you're diagnosed with LGS? You're already in the adult healthcare system. So what does that look like? So having some experts come together to say, okay, standard practice, every 5 years or whatever it is, if you have a patient that has uncontrolled epilepsy, you need to do a genetic test every 5 years or whatever. Come up with some kind of standards of practice that if you are treating any patient with uncontrolled seizures, this is kind of a protocol, standard of care that you would follow, and then get that published. And then I forgot who it was. Somebody had a really excellent idea about, we're going to take all this pile of cash and hire a PR firm so that we can really raise awareness and normalize, what these families are going through, and make it okay and make people feel more comfortable having engagements, having interactions, because Jen was talking about how people are afraid. people are afraid of folks who have seizures, but we need to really have somebody out there in the public, in media, on social media, and wherever we can to really have a strong PR campaign to raise awareness and get more information out there. So those were how we're going to spend those big giant piles of money.